Hello everybody. Today we will have the lecture Immunodeficiency Disorders. So, immunodeficiency disorders are disruptions of the normal immune status caused by a defect of one or more immune response mechanisms or non-specific defense factors. There are two types of immunodeficiency disorders: primary, hereditary, and secondary, acquired. International classification of disease number 10, it will be section D80, D89. Primary immunodeficiency disorders are only those caused by mutations of genes that determine functions of T or B lymphocytes, phagocytes, natural killer cells, complement system proteins, and etc. There are more than 80 types of primary immunodeficiency disorders. Incidence 1 to 400, 1 in 100,000. Location of genes responsible for immunodeficiency disorders are 1 to 5 to 5 to 11, 13 to 16, 19 to 21 chromosomes. Primary immunodeficiency types: B cell depend, antibody depend. In another way, it's about 50%. Combined types: B and C cell primary immunodeficiency disorders can be in 20% cases. T cell dependent 10%, phagocytic cell defect 18%, and complement system defect 2%. So, examples of primary immunodeficiency disorders: T cell disorders, D. George's syndrome. We can find the thymus aplasia and hypoplasia. So it's lead to immunodeficiency and hyperparathyroidism. Then B cell disorders, X-linked agammaglobulinemia, D80. In this case, we can find B cells maturation to plasma cells block. As a result, it will be the absence of plasma cells and antibodies. Then non-familial hypergammaglobulinemia. The number in classification of the international classification of diseases 80.1. It will be cells differentiation block with reduce of the level of immunoglobulins and increasing the susceptibility to infections. Just the same can we find in the case of common variable immunodeficiency with place in the international classification of diseases D83. So B and T cell level or in classification of diseases D81. Wiskott-Aldrich syndrome, D82. The primary position is the X-linked WASP gene defect, stem cell maturation disruption. We can find the severe damage of humoral and cell-mediated immunity, cancer, eczema, thrombocytopenia, autoimmune disorders. Extension. Autoimmune lymphoproliferative disorders, the pathology of fast antigen defects, and we can find B and T cell apoptosis disruption and autoimmunity. Then a very big quantity of different phagocytic and other immunodeficiency disorders. D89. The main representative of this group is chronic granulomatosis disease. We can find X-linked oxidative microbicidal systems of micro and macrophage autosomal defect. As a result, this could be the reduced killing of phagocytized microorganism and granuloma formation. And the pathology of complement system disorders, D84.1 in classification, it will be C1G subcomplement of the subcomponent of the complement. We can find chromosome 1 defect with the result will be the rheumatic diseases, systemic lupus erythematosus, and infections. And C3 complement, it will be a result of chromosome 19 and defect as a result of recurrent purulent infection. Very important scene is to know the main clinical features of primary immunodeficiency disorders. I show you the information concerning children, so major and minor. Major clinical features. It's the familial cases of hereditary immunodeficiency disorders. So we must speak very attentively and with the patient and ask the details in anamnesis morbis. Then otitis media, 8 and more episodes per year. Sinusitis, 2 and more episodes per year. Pneumonia, 2 and more episodes per year. Then antibacterial therapy failure of 2 months or longer duration, and live vaccine administration complications. So you see there are a lot of different kind of infections that of course will show the problems with the immune system, maybe with the deficiency of immune activity. And minor signs: visceral infections 2 or more times per year, recurrent skin and internal organs deep abscesses, child physical development delay with or without chronic diarrhea. Persistent candida infection of the skin and or mucous membranes in the first year of life. Spontaneous, acute or chronic graft versus host reaction. And recurrent or systemic infections caused by typical germs. So you see these main clinical features, and mainly they are depend of the different kind of infections that show the weakness of the immune system. Main etiological factors of secondary immunodeficiency disorders: physical, radiation, vibration, temperature; chemical, occupational, domestic, drugs; biological factors: bacteria, viruses, fungi, helminths, protozoa; and chronic starvation, of course. It can lead with weakness of immune activity, with the reduction of production of the antibodies. Tumors, diabetes, tuberculosis, and other chronic processes, and of course aging. Secondary immunodeficiency disorders features: first, absence of clinical manifestations in childhood and presence of immunodeficiency disorders reasons: T-cell mediated immunity and endogenous interleukin-2 production insufficiency; recovery of immunoglobulin secretion or other profoundly decreased immune status measures spontaneously or after immunotherapy. Major clinical syndromes of secondary immunodeficiency disorders: infectious, allergic, immunoproliferative or neoplastic, and autoimmune. Secondary immunodeficiency disorders immunological features: first, T-cell lymphopenia, the decreased level of the T lymphocytes with the cluster differentiation 3; dysimmunoglobulinemia, immunoregulatory index decrease lower than 1.3, lymphocytes activation factors expression increase CD25, C71, etc. Absorptive and digestive activity of phagocytes disorders: T helpers 1 and T helpers 2 activity prevalence with the corresponding cytokines production. Interferon status disorders: hypocomplementemia, natural anti-immune antibodies decrease or absence. Clinical patterns: masks of secondary immunodeficiency disorders, virus, bacterial, and fungal infections, lymphadenopathy, splenomegaly. So, clinical laboratory features of secondary immunodeficiency disorders: leukocytosis, leukopenia, lymphopenia, hypo or hypergammaglobulinemia, increasing of erythrocyte sedimentation rate and C-reactive protein, eosinophilia, and monocytosis are possible. Clinical laboratory features of secondary immunodeficiency disorders. T-cell-mediated immunodeficiency, leukopenia due to lymphopenia, the quantity of leukocytes less than 1,800, 50 to 70% of peripheral blood lymphocytes, T cells, you must know this. B-cell mediated immunodeficiency, lymphopenia, hypogammaglobulinemia, and low level of erythrocyte sedimentation rate. B-cell activation, autoimmune processes, lymphocytosis, hypergammaglobulinemia, high erythrocyte sedimentation rate. Clinical laboratory features of secondary immunodeficiency disorders. Leukopenia with granulocytopenia, transient granulocytopenia, sign of number of viral, bacterial and protozoal infection, neutropenia, sign of purulent infection in patients with immunodeficiency, monocytopenia in particularly unfavorable, less than 300 cells in 1 cubic milliliters. Secondary immunodeficiency disorders laboratory diagnostic. What is necessary to do? Humoral immunity assessment, immunoglobulin G, immunoglobulin A, immunoglobulin M. Antibodies to tetanus and diphtheria anatoxins, rubella and poliomyelitis viruses, Haemophilus influenza. As a hemagglutinin levels, cell-mediated immunity assessment, lymphocytes count, skin tests, immunoglobulin E level, phagocytosis assessment, phagocytes number and structure, complement system assessment, and the hemolytic activity and the level of the subcomponents of complement. Some words about immunodeficiency virus and AIDS. AIDS is, of course, the final stage of sexually transmitted infection, which is characterized by a continuously progressive course and high pathogenicity. So, in this case, we can speak about the secondary immunodeficiency disorder, which very often lead to the death of the patient if we will not do necessary treatment. Human immunodeficiency virus was first described in 1981. Then you see there were a rather long period of investigation with exploring of this virus, understanding the genetic structure of the virus, yes, the quantity and the quality of the genes, and the rule in which we can find these genes. You see this type, or rather maybe complex for this kind of virus. In this case, microscope picture, you can see the virus particles in the culture medium under an electronic microscope. So, of course, the result of activity of the virus infection when the human organism begins to suffer from this infection, and we can find the beginning of the secondary immunodeficiency disorder. The activity of the additional infection will grow, and at the beginning of the second stage of the infection is we can find the different pathology, infectious pathology of the different organs of the human being, yes, caused by the microorganism or other viruses that are not usual in average life in the human organism. And so at the beginning 107 cases of pneumocystic pneumonia were described in the United States before AIDS epidemic. The number of cases have risen during the epidemic in 1999. You see that calcination focuses form as a result of pneumocystic carina dissemination from the lungs to the different organs. In this case, we see kidneys. You see that 40 or 120 cases were reported before 1981 in the United States, and more than 46,000 cases were registered during the period more than 18 years of this infection. Also, we can find in the case of AIDS Kaposi's sarcoma. It's a rather severe disease that has the connection with the AIDS. So it can be the visit card of this virus and of the clinical stage of virus infection. Epidemiology, transmission mechanism, it's sexual. Men having sex with men are a major risk group in North America and Western Europe. Heterosexual transmission is the most prevalent transmission mechanism in developing countries. Blood products. Injecting drugs users are the second major risk group in North America and Western Europe. Hemophilic patients are being infected through contaminated factors 8. Then vertical transmission from a mother to the fetus varies from 15% in Western Europe to 50% in Africa. Vertical transmission consists of transplacental, perinatal, during labor, and postnatal when breastfeeding. Biological fluids that can transmit virus. Blood, sperm and ejaculate, vaginal and cervical secretes, breast milk. Virus can be also found in other substrates, but its respective concentration is small. Urine, cerebrospinal fluid, saliva, lacrimal fluid, respiratory gland secretion. AIDS statistics. Approximately 40 million people are virus infected worldwide. Approximately 14,000 people are newly diagnosed with this infection in yearly worldwide. More than 90% of them live in developed countries. 1,000 of them are children under 15 years. 48 of adults are women. 15% are 15 to 25 years old. What concerning genotypes, there are three HIV-1 genotypes: M main, O outliers, and N new. M group consists of large number of subtypes and recombinant forms. O and N group subtypes are not clearly defined. Different HIV-1 genotypes are not associated with the different disease cause and the response to antiviral therapy. However, some subgroups are difficulty diagnosed with available assays. Replications. The first stage of viral infection is binding of GP120 to the CD4 receptor on the cell surface, whereupon it enters the cell. Thereafter, the genomic viral RNA is being inversely transformed into proviral DNA by the reserve transcriptase and then integrates into the cellular genomes. Synthesis and mutual of new virions subsequently occurs. Half-life period. HIV infection cells activation results or in their death after 1-2 days. Production of viruses by short-lived activated cell results in a large number of viruses in the plasma. The time required to complete the life cycle of an individual HIV particle is approximately 1.5 days. HIV-infected CD4 T cells starts producing the virus only after the immune stimulation. Such cells have a half-life of at least 5-6 months. Some of the cells are infected with a defective virus which doesn't pass the full life cycle. Such cells are long-lived from 3 to 6 months. Such cell population is a major problem in the context of the antiretroviral therapy. Pathogenesis. AIDS is characterized by a profound immunosuppressive suppression resulting from the progressive CD4 T helpers lymphocytes number reduction. High level of HIV are determined in the initial post-infection period. There is a declining levels of HIV during the incubation period, and also a restoration of CD4 T lymphocytes number after the initial decline. Subsequently, the immune system becomes depleted and AIDS symptoms develop when the content of CD4 T lymphocytes is not restored for a long time. The signs are high HIV load and HIV antigen presence, and low levels of CD4 cells. You can see CD4 T lymphocytes is a prime target for HIV. How does HIV penetrate CD4 T lymphocyte? You see that it's necessary to have the special antigen in the surface, on the surface of the human cell, and the virus will have the contact with this CD4 antigen. So only 1 to 10,000 cells is infected in early stage of infection, and 1 to 40 in the advanced stage. So you see in this page the pathognomonic laboratory sign in a gradual decrease in CD4 cells number in T lymphocytes up to complete disappearance. You see in this picture. It's very sad picture. Of course, you must know that HIV infection affects not only CD4 cells, also they can penetrate intestinal and vaginal epithelial cells, endothelial cells, brain cells, astrocytes, oligodendrocytes. Clinical symptoms. Seroconversion illness is observed in 10% of patients within a few weeks after infection and coincides with a seroconversion. It manifests with symptoms similar to infectious mononucleosis. The incubation period is the period of clinical symptoms absence. Its duration varies from several months to more than 10 years. On average, it lasts for 8-10 years. AIDS-related complex or persistent generalized lymphadenopathy, and at last AIDS. You see the cellular immunological pattern of disease or acute infection. You see with the degrees the level of the CD4 T lymphocytes. Yes, firstly, for the lowest level, the concentration of these cells reduced. So we see the high viral titer, pronounced symptoms absence, of course, CD4 cells decreased to subsequent normalization, and CD8 cells increased for subsequent normalizations. Some subsequent normalization, of course. Clinical entomological pattern, disease course. And at last you see then T cell concentration continue to reduce, and it will be the attempt to increase the level of HIV antibodies, but then it will be the weakness of the activity and the immune system and reduction of the quantity of these antibodies. HIV and AIDS, clinical entomological pattern, disease course. You see the CD4 T cells concentration is reduced. So the reduction at last, the quantity of CD8 T cells, yes, and the quantity of virus after some period of decreasing will increase, and the disease will continue. So AIDS clinical criteria, major symptoms, weight loss of 10% and more, chronic diarrhea more than 1 month, fever more than 1 month. Minor symptoms, persistent cough 1 month and more, generalized pruritic dermatitis, recurrent herpes zoster, oropharyngeal candidiosis, chronic progressive disseminated TSV infection, generalized lymphadenopathy. In the presence of the least 2 major and 1 minor symptom, 8 is diagnosed generalized Kaposi's sarcoma and Cryptococcus meningitis. Other manifestations. It has now been shown that HIV infection patients develop in the disease which cannot be explained by opportunistic infections or tumors. The most common neurological manifestations is encephalopathy, which is seen in 2 set of AIDS patients. Other disease manifestations include skin rashes and persistent diarrhea. Clinical signs monitoring of infected patients. Examination area, sign and possible causes. General, weight loss, HIV-related Western syndrome, fever, Mycobacterium avium, intracellular tuberculosis, lymphoma without localized infection sites. Eye fundus, white retinal patches, cotton wool spots as possible causes. Yellow-white retinal infiltrates, CM, as a result of CMV or Toxoplasma retinitis. Retinal hemorrhages, CMV retinitis. Visual fields, side disturbance, CMV retinitis. Oral cavity, white patches, candidiasis, hairy leukoplakia. Ulcers, HSV, CMV after viola cirrhosis, molecular or papillus. Kaposi's sarcoma, bacillar angiomatosis, and lymphatic nodules, lymphadenopathy is HIV-related lymphadenopathy, lymphoma, tuberculosis, and syphilis. Continue. Abdominal cavities, capital of splenomegaly. It's Mycobacterium avium, tuberculosis, lymphoma, histoplasmosis. Perirectal ulcers, HSV, CFV. Genitalia, condyloma, HSV, genital sores. Syphilis, HSV, chancroid. Nervous system, motor dysfunction, CNS, toxoplasmosis, lymphoma, syphilis, progressive multifocal leukoencephalopathy, HIV-associated neuropathy. Skin, violet papules or macules, Kaposi's sarcoma, bacillar angiomatosis. Peeling, seborrheic dermatitis, fungal infection, psoriasis. Purpura, HIV-related idiopathic thrombocytopenia purpura. And vesicular rash, the result of herpes zoster, drug reaction, and HSV. So, HIV-infected long-term non-progressors. Individuals with HIV infection for more than 7 years have stable number of CD4 T cells, more than 600 cells for 1 millimeter in cube. Don't have disease clinical symptoms. Don't receive chemotherapy. 25% of them have mutant CCRP. Laboratory diagnostic serological methods are the most commonly used for the diagnostic of HIV. ELISA is the most commonly used screening method. Western blot is considered a gold standard confirmatory method. You see, this is the picture of the different HIV detection methods. So, they say for anti-HIV antibody detection, you see the microplate for anti-HIV antibody detection stained cells indicate reactivity. Immunoblot, they say that allows to identify, confirm the presence of antibodies specifically reacting with selected pathogen antigens, proteins in the sample, serum, plasma, or and to reveal presence characteristic seroconversion. So we know to use that we will use the Western blot for HIV antibodies detection, and we have also other diagnostic assays. Typically, anti-HIV antibodies appear in the serum in 4-6 weeks after infection. Diagnosis of HIV infection can be made by HIV antigen detection during this time frame. In some cases, it is possible to exclude the presence of HIV infection in a child of the HIV-infected mother using methods that detect HIV antigen such as PCR and predictive test. From the moment of HIV infection diagnosis, it's extremely important to regularly monitor the patient for disease progression signs and the antiviral therapy effect. Viral load is the number of HIV copies in the certain volume of serums that are detected by means of modern methods. Currently, viral load determination is considered to be the most reliable predictor and a way to monitor the antiviral chemotherapy effectiveness. You see a strong correlation between the number of viral particles as determined by PCR and disease progression. You can be attentive. And initial virus load and median viral association also rather strong. And in this picture you will see the number of CD cells and AIDS progression association. So you see the connection between the number of CD40s lymphocytes and disease progression. Antiviral sensitivity testing. In the current accepted that antiviral sensitivity testing should be an integral part of HIV-infected patients' management. It is believed that test results should be interpreted by experts in the field. There are two approaches into antiviral sensitivity testing. Phenotypic, very complex to implement and extensive, also helps to gain more accurate pattern of the real situation in vivo. Genotypic, real-time polymerase chain reaction and protease gene sequencing. These methods are now available and the results are interpreted automatically using the American HIV sequencing database. Now we have a lot possibilities for treatment. I think you will read attentively, but I think it's not the main item of our lecture. And what about prophylactic? The risk of HIV infection increases with the number of sexual partners. Lifestyle modification reduces the risk. The spread of HIV through blood and blood products is actually reduced to zero since the introduction of blood donor screenings. ICT appeared to be effective in preventing the transmission of HIV from mother to a fetus. Cases of HIV infection in children have decreased by 2%. Vaccines are constantly being developed, but the high variability of HIV alters this process. So continue. Immunoprophylaxis, what does it mean? The system of measures implemented to prevent, limit and eliminate the spread of infectious diseases through preventive vaccination. Immunoprophylaxis, infectious disease specific prophylaxis. Type of immunoprophylaxis: active, anatoxins, passive serums, immunoglobulins, passive active serum plus anatoxin. Anti-infective immunity, nature of acquired immunity, and mode of acquisition. Active, natural, past infection, of course, in this case. Adaptive, it's necessary to do vaccination. And passive, natural, transplacental, placental or colostral transfer of antibodies from a mother to a fetus. Adaptive, administration of immunoglobulin preparations containing antibodies to infectious agents. Vaccination is a method of creating an active immunity against infectious diseases by administering of special preparation vaccines to a human or an animal. There are a lot of chronic somatic disease that with proved associations microorganisms. So, well, not when we speak about vaccination, about the role of infection in development of some kind of disease, it's naturally that the infections, viruses, bacteria, different bacteria can lead to the clinical features, to the diseases with many clinical features. This it will be infectious diseases, but there are a lot of somatic diseases, chronic somatic diseases that have the very close contact or association with the microorganism. It's very important thing in this case. We will have the additional possibility to help the person, and we have the very important way for development our knowledge in the field of the immunotherapy. So, systemic organ class, cardiovascular pathology, diseases, myocardial infarction, stroke, myocarditis, atherosclerosis, and there are a lot of microorganisms that can, I think, take part in the development of this kind of diseases. They are influenza virus, Coxsackie B virus, hepatitis C virus, chlamydia, pneumonia, you can see on the table. Gastrointestinal, peptic ulcer, gastritis, Helicobacter pylori. Now everybody know about this, and some people received the Nobel Prize. They are winners of Nobel Prize for this extraordinary discovery. Metabolism, type 1 diabetes, insulin-dependent rubella virus, mumps virus, Coxsackie B virus, and reproduction or hiatus. And of course, we have the virus that can, mumps virus, that can lead to development of this disease. Neoplasm associated with infection, stroke, adenocarcinoma, lymphoma, extranuclear, liver, hepatosarcoma, and they have the association with Helicobacter pylori, extranuclear, human papilloma virus, and hepatosarcoma and hepatitis C, first of all, and I suppose also hepatitis B. Vaccines that proved or presumed ability to prevent the development of so-called non-communicable diseases. Vaccine to influenza, condition, stroke, myocardial infarction effect proved during the influenza epidemic rise. Hepatitis B, hepatitis sarcoma, preliminary data available, study continues. Rubella, neonatal diabetes mellitus expected, mumps, male infertility expected, papillomavirus, cervical carcinoma. Clinical trials are undergoing. There are a lot of different types of vaccines, live vaccines, killed or inactivated vaccines, chemical vaccines, synthetic peptide, recombinant vaccines, DNA vaccines, idiotypic vaccines, anti-idiotypic vaccines, associated or combined vaccines. There are a lot of different types. The ideal vaccine must satisfy the following requirements. What requirements can be? Induce lifelong immunity in 100% of vaccinated after single administration. Be polyvalent. So what does it mean? Contain antigens of the maximal number of infectious diseases. Be safe and not require cold chain. Be administered orally. And passive immunoprophylaxis. Immunoglobulins or serum containing specific anti-infective antibodies administration. Passive immunity. It can be natural and adaptive. There are a lot of immunoglobulins preparation in human normal immunoglobulin, human immunoglobulin G, and hyperimmune immunoglobulin preparation, and methods to influence the immune system. You must know that there can be immunocorrection, immunostimulation, and immunorehabilitation. So, thank you for your attention. Bye-bye.